You know, when you think about the most common medical conditions out there, your mind probably jumps to things like, I don't know, asthma or maybe diabetes, right? You
Yeah.
picture inhalers, you picture these massive public awareness campaigns, telethons, all that funding. But here's just a staggering statistic to kick off today's deep dive for you. Chronic insomnia affects roughly 10 to 15% of all adults.
Yeah, and that's just the chronic cases.
Right. And if you count people who just experience, occasional disruptive symptoms, that number jumps to over 30%. I mean, it is
Yeah.
actually significantly more common than asthma, yet it just completely lacks that same level of, I guess, medical urgency in our culture.
It is, it's really incredible when you consider how we usually treat it, because for decades, it has just been dismissed as this sort of minor complaint. Someone mentions they aren't sleeping, and the response is usually just a shrug or like advice to drink some chamomile tea or something. We treat it like a bad mood rather than, a debilitating physiological state.
Yeah. Yeah, take a warm bath, you'll be fine. Which honestly brings us to our mission for you today. We are exploring this fascinating stack of medical history, clinical guidelines, and modern sleep science research to fundamentally rethink insomnia and sleep disorders. We're going to, uncover what actually happens to the brain and body when sleep fails, how these sleep problems fundamentally alter mental health, and why basically everything we think we know about curing a bad night's sleep is probably completely backwards.
Yeah, completely backwards is right. But to do that justice, we really have to establish a clear baseline first. Because the phrase, "I have insomnia," gets thrown around constantly, right? Someone has a bad night before a big job interview and they're like, "Oh, I have insomnia." But clinical insomnia is not just a temporary bout of nerves. According to the current diagnostic manual, the DSM-5-TR insomnia disorder is specifically defined by two critical factors, and those are distress and impairment.
Okay, so it has absolutely nothing to do with like hitting a specific number on a clock.
Yeah.
You can't just say, I only slept 6 hours, therefore I have a medical disorder.
Exactly. No, plenty of people sleep 6 hours a night and function perfectly fine. They're just, natural short sleepers.
Sure.
But conversely, someone else might sleep 8 hours, but the quality is so fragmented that they feel completely wrecked the next day. So to meet the clinical criteria, you have to be deeply dissatisfied with your sleep quantity or quality.
Right.
That means having trouble falling asleep, staying asleep, or waking up way too early and just, not being able to coax your brain back offline. And this has to happen at least 3 nights a week, persist for at least 3 months, and this is key. It must happen despite having the adequate opportunity to sleep.
So you aren't just like working a grueling night shift and literally lacking the time to sleep.
Right, exactly. But the final clause is really the anchor here. It has to cause meaningful distress or impairment in your daily functioning, like in your work, your relationships, your emotional regulation. True insomnia is defined entirely by the suffering it causes.
It's wild to think about that level of chronic suffering, especially because, for decades, if a patient described that exact torment to a doctor, the medical establishment would essentially just tell them it was a side effect of something else, right? They completely misunderstood its relationship to mental health.
Oh, completely. There was this massive paradigm shift in 2013 with the release of the DSM-5. Historically, if you looked at the older diagnostic manual, the DSM-IV, insomnia was split into two separate categories. You had primary insomnia, meaning it happened entirely on its own, and secondary insomnia, meaning it was presumed to be caused by another underlying condition.
Okay, wait, let's unpack this because like someone going through major depression or dealing with chronic back pain, right? The assumption was that the sleep issue was just a symptom downstream of the quote-unquote real problem. And that old logic makes intuitive sense on the surface.
It does, yeah. Clinicians were explicitly taught to view it exactly that way. The standard practice was just to treat the underlying cause, give the patient an antidepressant or, manage their physical pain. And doctors just assumed the insomnia would naturally resolve itself once the main fire was put out.
Right, like if you have a leaky roof and it ruins your floor, you don't just keep replacing the floorboards, you fix the roof. So fixing the depression should fix the sleep. But looking at the source material, that assumption was actually quite dangerous for patients.
It was incredibly dangerous. It left millions of people suffering. Large-scale studies throughout the 1990s and 2000s, especially the foundational research by sleep scientists Michael Perlis and Charles Morin, they proved that assumption was just fundamentally flawed. They conducted these rigorous longitudinal studies tracking patients over long periods of time and showed that insomnia frequently persists as a completely independent problem, even after the quote-unquote primary condition is successfully treated.
Wow, so someone go through therapy, takes their medication, their depression lifts, their mood improves, but they are still lying awake at 3 a.m. just staring at the ceiling.
Exactly. The sleep problem mutates into its own beast. And the research revealed something even more alarming. The link between insomnia and mental health is actually bidirectional.
Bidirectional, meaning it goes both ways.
Yes, insomnia doesn't just follow depression as a symptom. The data clearly shows that chronic insomnia actually precedes and predicts the onset of a depressive episode. So if you take a group of people with no history of depression, the ones struggling with chronic sleeplessness are at a massively higher risk of developing major depression down the line. Untreated insomnia is a massive, independent mental health risk factor.
Which completely shatters that old primary and secondary distinction. I mean, if the sleeplessness is causing the depression, it's not a symptom, it's a catalyst.
Precisely. And the 2013 DSM-5 update finally reflected this hard-won realization. They collapsed the categories into a single diagnosis, just called insomnia disorder. It sends a clear message to clinicians that sleep problems deserve their own independent, aggressive treatment, regardless of whatever else the patient is dealing with.
It really completely reframes what we think of as sleeplessness. It isn't just, lying in bed feeling a bit restless. It's waking up at 3 in the morning, the house is dead silent, and you are trapped in the dark with your own racing thoughts for hours on end. And when you picture that kind of profound isolation and exhaustion night after night, the bridge to severe anxiety and depression becomes, well, glaringly obvious.
It is just a devastating cycle to be caught in.
Which honestly makes me wonder about the physical mechanisms here. Because if insomnia is this standalone disease with these deep, dangerous ties to our mental health, what is physically breaking down in the body? Like, we need to look under the hood and figure out why the engine just refuses to shut off.
To understand the mechanics of sleep failure, we first have to really understand normal sleep architecture. So back in 1982, a Swiss researcher named Alexander Borbély proposed what we now call the two-process model. He mapped out that healthy sleep is governed by two entirely independent biological systems that are just constantly interacting. The first is process S, which is your homeostatic sleep drive.
Okay, homeostatic meaning balance. So this is the system that builds up the physical hunger for sleep the longer we are awake. And I know adenosine plays a big role here, right? It's a neurochemical that accumulates in the brain throughout the day, binding to receptors and creating that intense pressure to sleep. This is why pulling an all-nighter feels so agonizing by, 4 a.m.
Yeah, adenosine is the perfect example of process S in action. The longer you stay awake, the more it builds up and the heavier your eyelids feel. Incidentally, this is the exact mechanism of caffeine. The caffeine molecule is shaped really similarly to adenosine, so it sneaks into those brain receptors and literally blocks the adenosine from binding, artificially masking that sleep pressure.
Right, okay, so if adenosine just builds and builds, we should just eventually pass out no matter what, right? But anyone who has pulled an all-nighter knows that if you can just survive until the sun comes up, you suddenly get this weird second wind. You actually feel less tired at 8 a.m. than you did at 4 a.m., even though you have been awake longer. So there has to be a second system fighting that adenosine pressure.
Exactly. And that is process C, the circadian rhythm. It's an internal, roughly 24-hour biological clock run by a tiny cluster of neurons in the hypothalamus called the suprachiasmatic nucleus.
Say that 3 times fast.
Right. But this master clock regulates your alertness completely independent of how long you've been awake. It relies heavily on environmental cues, primarily light exposure, to tell your body when to be alert and when to power down. So healthy sleep happens when these two systems perfectly align. You have high sleep pressure from a long day of adenosine buildup, meeting a natural dip in alertness commanded by your circadian clock.
So process S is sort of like the battery draining on your smartphone. The longer it's unplugged, the lower the battery gets. But process C is like the screen's auto brightness feature that adjusts entirely based on the ambient light in the room or the time of day. So insomnia is basically when your battery is at 1%, you are completely drained, but your brain's brightness is inexplicably stuck on maximum.
That is a phenomenal way to visualize it. The physical exhaustion is absolutely there, but the neurological alertness refuses to yield. And what happens next is that the frustration of being drained but unable to sleep becomes its own massive obstacle. Which brings us to a really crucial concept called the hyperarousal model.
The idea that the engine is just, running entirely too hot.
Yes, medical science used to view insomnia as a localized problem, like just a nighttime switch that failed to flip. But researchers started measuring the physiological markers of insomnia patients around the clock. They looked at 24-hour cortisol levels, metabolic rates, and heart rates, and they discovered that people with chronic insomnia are physiologically more aroused all day long.
Wait, all day, not just at night.
All day. Their bodies literally run a notch hotter from morning to night. They have elevated stress hormones, their core body temperature is slightly higher, and they exhibit more beta wave brain activity, which are the fast brain waves associated with active, engaged problem solving, even when they're just sitting quietly during the day. Insomnia is a 24-hour disorder of an overactive, hypervigilant nervous system.
Well, if the entire nervous system is locked in overdrive, it completely explains why so many common quick fixes fail spectacularly. Like, take the classic nightcap, right? People have a quick drink before bed to force themselves to power down.
Oh, alcohol is arguably the most misunderstood sleep aid in the world. It acts as a central nervous system depressant. So yeah, it might shorten the time it takes to initially lose consciousness. It gives you that heavy, sedated feeling. But metabolizing alcohol creates a massive rebound effect later in the night. It severely suppresses your REM sleep, which is critical for emotional regulation, and it fragments your sleep architecture. You might be unconscious, but you end up with much lighter, highly disrupted, totally unrefreshing rest.
Yikes. Okay, what about the weekend catch-up strategy? I mean, so many people do this. They'll just grind through the work week on 5 hours a night and then try to sleep 12 hours on Saturday to clear the debt. But if they're aggressively shifting their sleep schedule by 4 or 5 hours on the weekend, wouldn't that completely scramble that process C circadian rhythm we just talked about?
It does. Researchers actually have a name for that specific phenomenon. They call it social jet lag. Getting that weekend recovery sleep might restore a tiny bit of basic functioning, but it doesn't fully reverse the complex cognitive deficits you accumulated during the week. And, by sleeping in until noon on Sunday, you severely delay your circadian clock. Come Sunday night, your body thinks it's early evening, making it essentially impossible to fall asleep for work on Monday.
So you're essentially flying from New York to London and back every single weekend without ever leaving your bedroom.
Exactly. It creates a permanent state of biological confusion.
Which raises the ultimate question, I think. If the brain is running hot all day, and quick fixes like alcohol or sleeping in just make it worse, how does a bad week turn into a lifelong chronic disorder? Because everyone experiences stressful events that ruin their sleep temporarily. Why do some people bounce back while others get trapped in a decade-long battle with insomnia?
The answer there lies in human behavior, specifically how we react to the temporary sleeplessness. Back in 1987, a psychologist named Arthur Spielman published a massive theoretical breakthrough called the 3P model. And he argued that chronic insomnia is constructed from 3 interacting factors: predisposing, precipitating, and perpetuating.
Okay, let's walk through a realistic scenario with those 3 Ps, because that's a lot of Ps.
Fair enough. The first layer consists of predisposing factors. This is your baseline trait-level vulnerability. So someone might have a naturally anxious or ruminative temperament, a hyperreactive nervous system, or maybe a family history of sleep struggles. They are biologically primed for the issue, but they might still sleep perfectly fine most of the time.
So the dry brush is there, just waiting for a spark. Yep. Which brings us to the precipitating events, right?
Right. This is the acute stressor: a messy divorce, a sudden medical crisis, losing a job, or even a positive stressor like having a new baby or starting a high-stakes job. This event triggers the hyperarousal, and suddenly they aren't sleeping.
But the stressor eventually fades, right? Divorce gets finalized, you settle into the new job, the precipitating event ends. So why doesn't the sleep just return to normal?
Because of the third P, which is the trap that turns a temporary disruption into a chronic disease, and those are the perpetuating behaviors. These are the coping mechanisms people adopt to survive the bad stretch of sleep. So they start napping during the day to take the edge off. They start constantly checking the clock at night, doing that, mental math of how much sleep they can still get if they fall asleep right now. Or they develop intense dread about bedtime itself. But the most insidious perpetuating behavior is simply lying in bed for 9 hours, hoping to catch just 6 or 7 hours of sleep.
Okay, I have to pause here because that seems entirely counterintuitive.
Yeah.
If you're exhausted, shouldn't you just stay in bed, keep your eyes closed, and rest? I mean, isn't resting quietly in the dark almost as restorative as sleeping?
That is the single biggest trap in sleep medicine. Remaining in bed while awake and frustrated teaches your brain to associate the physical environment of the bed with wakefulness, clock watching, and anxiety. You undergo classical conditioning, much like Pavlov's dogs. You are literally training your brain that the mattress is a place to be alert, stressed, and hyper-aroused.
Wow, so you basically turn your own bed into an anxiety machine. You walk into the bedroom, and your brain just says, oh, this is where we do the tossing and turning and panicking.
Exactly. And understanding that psychological trap led to the development of behavioral therapies that sound completely backwards but are incredibly effective. These strategies actually form the core mechanics of what we now call cognitive behavioral therapy for insomnia, or CBT-I. The first pillar is stimulus control therapy, which was developed by Richard Bootson in the 1970s. The rule is brutally simple. If you aren't asleep within about 20 minutes, you must get out of bed. Go to another room, read a boring book in dim light, and only return to the bedroom when your eyelids are heavy. You have to aggressively rebuild the mental association that bed equals sleep and literally nothing else.
That makes a lot of sense, even if it sounds terrible in the moment. And the second pillar of CBTI is even more extreme, isn't it?
Oh, yeah. Sleep restriction therapy, developed by Spielman himself. You deliberately calculate your current average sleep time, let's say it's only 5 hours a night, and you restrict your time in bed to exactly that window. If you only sleep 5 hours, you only allow yourself to be in bed for 5 hours total.
So if you have to be up at 6 a.m., you are not allowed to get into bed until 1 a.m., even if you are dead tired at 10 p.m. on the couch. You have to force yourself to stay awake.
Yes. It forces the sleep pressure, that process adenosine buildup we talked about, to concentrate intensely. It eliminates all the shallow, fragmented tossing and turning. You consolidate your sleep into a dense, solid block. Once your sleep efficiency improves and you are sleeping solidly through that 5-hour window, you gradually extend the time in bed by maybe 15 minutes at a time. Patients fight this therapy fiercely at first because it sounds like it will just make them more exhausted.
I mean, I would fight it.
Right, but it is one of the most robust findings in modern sleep science. By fixing the perpetuating behaviors, it actually repairs the architecture of your sleep.
Well, if behavioral therapies like sleep restriction and stimulus control are so incredibly effective at rewiring the brain, why is our modern culture so completely obsessed with using pills and gadgets to fix sleep?
Because behavioral change is really hard work, and pills are heavily marketed as a fast, effortless fix. Throughout the 1990s and 2000s, there was this massive pharmaceutical boom targeting sleep. The industry heavily pushed benzodiazepines and later the Z-drugs medications like Zolpidem, which most people know as Ambien. For a while, Ambien was a genuine blockbuster drug, handed out for nearly every sleep complaint.
But the source material highlights a really dark side to that pharmaceutical boom, right?
Absolutely. These hypnotic medications basically act as chemical sedatives. They suppress the symptoms temporarily, essentially just knocking the brain out, but they do absolutely nothing to address the underlying hyperarousal or those 3P perpetuating behaviors driving the disorder. Worse, evidence rapidly mounted regarding tolerance, physical dependence, and severe rebound insomnia, meaning the sleep is much, much worse when patients actually try to stop taking the drug. And then there were the deeply concerning complex sleep behaviors.
Like sleepwalking.
Oh,
But far more extreme, right?
much more extreme. People were sleep eating entire meals, making phone calls, and terrifyingly, sleep driving. People were getting into their cars and driving down the highway completely unconscious, with absolutely no memory of it the next day. The adverse event reports piled up to the point that in 2019, the FDA was forced to add a black box warning to Ambien and similar drugs. That is the strictest, strongest possible safety warning the agency can issue.
Which kind of paves the way for CBTI to take the crown, I guess. Because if the pills are dangerous and only mask the symptoms, the behavioral therapies are the actual cure.
The data strongly supports exactly that. In 2004, a landmark trial led by researcher Greg Jacobs was published in the Archives of Internal Medicine. They directly compared CBT-I against Ambien for treating chronic insomnia, and the results were just striking. CBT-I produced better, more durable, long-term outcomes. The drug's benefits vanished almost immediately when patients stopped taking it, but the patients who underwent CBT-I maintained their sleep gains long after the therapy ended because they had actually dismantled the mechanism of their insomnia.
They fix the engine rather than just covering up the check engine light with a piece of tape.
Exactly. And based on a mountain of similar evidence, the American College of Physicians issued updated clinical guidelines in 2016 naming CBT-I not medication as the recommended first-line treatment for all adult chronic insomnia.
The bitter irony here, though, is that while the medical field is moving away from pills, consumers have found a brand new way to manufacture sleep anxiety using modern technology. So if you are listening to this right now wearing a smartwatch or a sleep tracker on your wrist, pay close attention. In 2017, researcher Kelly Barron coined a term for a very modern affliction. She called it orthosomnia.
Orthosomnia is such a fascinating paradox. Millions of people are using these wearable sleep trackers with the absolute best of intentions, to monitor and optimize their rest. But they become so fixated on achieving the perfect sleep score or hitting this arbitrary percentage of deep sleep that the anxiety about the data actually causes the insomnia.
The wearable tech, meant to diagnose and improve the problem, is literally manufacturing the hyperarousal. They wake up, check their watch, see a low score, and immediately flood their system with stress hormones. It's just a brand new perpetuating behavior to add to the 3P model.
It perfectly illustrates how psychological our relationship with sleep really is.
Yeah. And to really cement why we need to take all of this seriously, like why sleep is absolutely non-negotiable biological maintenance, the source material provides two extreme scientific milestones that demonstrate what happens when sleep fails completely. The first involves a 17-year-old high school student named Randy Gardner back in 1964.
Oh, the Gardner case. Yeah, so Randy Gardner decided to see how long he could stay awake for a San Diego Science Fair project. He was closely monitored by William Dement, a researcher who had studied under Nathaniel Kleitman, the man often called the father of American sleep research.
And Gardner managed to stay awake for 11 days, 264 hours without a single drop of sleep, which is just terrifying.
And researchers documented his brain slowly breaking down in real time. After a few days, his mood became intensely irritable and his coordination faltered. By the end of the experiment, he was experiencing severe cognitive lapses, profound paranoia, and vivid hallucinations. I mean, he believed a street sign was a person, and he became convinced people were conspiring against him. While he did recover fully after finally being allowed to sleep, it was such a dramatic, real-world demonstration of how quickly the brain's processing centers degrade without rest that Guinness World Records actually stopped recognizing sleep deprivation record attempts entirely, citing the extreme health risks.
I mean, rightfully so. And if temporary psychosis isn't extreme enough, there is a condition called fatal familial insomnia, or FFI. This isn't clinical insomnia driven by hyperarousal like we've been discussing. It is a very rare inherited prion disease. It was first deeply documented in an Italian family in the 1980s by a physician named Ignazio Reuter.
Right. And prion diseases occur when normal proteins in the brain fold abnormally and clump together. In the case of fatal familial insomnia, these misfolded proteins specifically target and destroy the thalamus, which is the region of the brain that essentially acts as the gateway regulating sleep and sensory information. As the thalamus degenerates, patients progressively lose the physical ability to enter deep sleep.
It is a stark, deeply tragic biological reminder of the stakes here. Total permanent sleep loss literally destroys the brain. Patients suffer worsening panic attacks, hallucinations, and rapid physical decline, typically dying within roughly 1 to 2 years of the onset of symptoms. It underlines the absolute non-negotiable truth that sleep is not optional downtime. It is active, vital physiological maintenance.
It is the foundation of everything.
So what does this all mean for you as you navigate your own sleep habits? We live in an incredibly taxing modern era. We saw a massive wave of what people called coronasomnia during the pandemic stress. We sleep with smartphones emitting circadian disrupting blue light right next to our pillows. We navigate shift work and an always-on corporate culture that actively erodes the quiet conditions that sleep fundamentally depends on.
We have to recognize that chronic sleep problems aren't a character flaw. It is not a weakness you can just push through with willpower or an extra cup of coffee.
Exactly. It's a mechanistically specific, highly treatable disorder. If you are struggling with chronic insomnia, ignoring it is a direct gateway to depression, anxiety, and metabolic dysfunction. It degrades workplace safety. It leads to thousands of drowsy driving accidents every year. It's a major public health issue that requires serious targeted treatment like CBT-I, not just a glass of wine or an extra hour in bed on Sunday to clear out a week of social jet lag.
Well said. And, to leave you with something to truly ponder, there is one final, deeply baffling phenomenon from the diagnostic manual that I think just perfectly encapsulates the sheer complexity of everything we've unpacked today. It is a specialized subtype called paradoxical insomnia. Imagine lying in bed feeling agonizingly, vibrantly awake. You hear the clock ticking, you toss and turn, you watch the shadows move across the ceiling, and this torment goes on for weeks. You are utterly convinced you are getting zero sleep. You feel the deep distress, you experience the daytime impairment. But if doctors bring you into a sleep lab and hook you up to polysomnography equipment, monitoring your brain waves, your eye movements, your muscle tone, the objective data shows something impossible. Your sleep architecture looks completely perfectly normal. The monitors say you were deeply asleep, while your subjective experience says you were agonizingly awake. It is a profound, somewhat chilling reminder that the human perception of suffering, the feeling of being trapped in sleeplessness, can be just as clinically significant and just as tormenting as the physical reality itself.